Good evening, everyone, and thank you very much for joining us this evening. My name is Sulma Nardino, and I'm the Director of Programs for the Riverside County Medical Association. And this webinar is a member benefit of the Riverside County Medical Association for all of our members and resident members. Welcome to our webinar, Difficult Patient Relationships, Rehabilitate versus Terminate. Our speakers are Kathy Salois and Stacy Stauffer. Both are senior risk management consultants with ProAssurance who advise physicians and other healthcare providers on professional medical liability risk issues. And now I will hand off the presentation to Kathy Salois.
Well, thank you so much, Zulma. And welcome everyone to our presentation. Before I begin the program content, I do have a couple of items that I have to quickly review. This program has been designated for a maximum of 1 CME credit. You should claim only the credit commensurate with the extent of your participation in our activity. A link will be placed in the chat, and you'll also receive a link to complete the survey so that you can obtain your CME certificate. The information contained in this presentation, it's intended as risk management advice. It does not constitute a legal opinion. It's not a substitute for legal advice. So if you do have any legal inquiries about any of the topics that we discussed during the presentation, you should direct those to an attorney. The faculty and planner for today's program have no relevant financial relationships to disclose. And now I'd like to review our learning objectives and how they're hopefully going to support your ability to recognize associated risks with difficult patient interactions, and then to identify contributing factors that may trigger disruptive behaviors. To utilize concepts for conflict de-escalation, and to develop guidelines for staff to aid in handling various types of patient communication. And then finally, our last objective is to apply risk management strategies for improved patient engagement and patient safety. So moving right along, knowing how to properly approach difficult patients, that always has and always will be an essential skill for every physician and their staff, but it may be more important than ever given the current environment. So the MGMA did a recent poll, and they found that 71% of medical providers reported an increase in the number of disruptive patients that they saw in 2021. And respondents reported a number of issues that contributed to the increase. The first was refusal to wear masks in facilities. That was the most frequently cited reason for a disruptive patient. Disruptions also emanated from patients who refused to believe that they had positive COVID-19 results, and also from patients who refused to take COVID-19 tests or even submit to those screening procedures. Like, remember when we used to have them take their temperature when they walked in the door? They didn't want to do that either. Additionally, respondents cited patients' dismay over visitor policies that limited the ability of children or other guests to join the patient in the facility. And then finally, as you can imagine, frustration over scheduling issues and patient wait times were also reported. Now, while all of these issues are COVID related, there are also a host of other factors that can contribute to similar difficult patient encounters, and I'm going to review a couple of those too. Excuse me. So aside from the increased stressors of COVID contributing to the current climate involving these difficult patient scenarios, oftentimes it's more than just the difficult patient being irrational or unruly. A combination of factors usually contributes to the difficult patient encounter, so I'm going to review a few of them. First, patient factors may give rise to difficult clinical encounters. Patients that exhibit certain characteristics can make it hard to have a productive outcome, and these characteristics may include those with maybe an abrasive personality, or those that can make them seem inflexible, or like they may anger easily. And then there are patients who can be manipulative and demanding in an attempt to direct their treatment. So an example would be demanding unwarranted tests or medication, or even threatening legal action or self-harm if you don't do what they want you to do. There are other patients who present with multiple complaints, vague and or exaggerated symptoms, plus they may be extremely talkative. If you're lucky, you get me as a patient, and then you'll find out what that's all about. And this can interfere with adequate timelines while you're attempting to obtain a clinical history. Now, these scenarios can often be linked to anxiety, depression, or even a personality disorder. I'm sure you know that some of the most common difficult patients are those who are non-compliant or those who are exhibiting drug-seeking behaviors. Now, the surrounding environment also has various contributing factors as well. Language and cultural barriers during communication attempts, that can cause frustration for both the provider and the patient, right? In that case, an interpreter might be necessary, and that increases the time needed for the exam. But you know, an interpreter can be really helpful in distinguishing cultural influences when you're trying to obtain clinical information. And what about consumer advertising? There's an abundance of conflicting medical information online, and that can set the stage for patients to have unrealistic expectations, and that will lead to dissatisfaction. As I said before, not prescribing what the patient thinks that he or she should have, something they saw in an advertisement or on the internet. And this results in patients becoming more demanding, right? Another environmental influence can be changes in insurance and access to care, which can also disrupt continuity of care. And that can be upsetting to the patient. And I'm here to tell you that that is absolutely the truth, because I recently just had to switch my care to Medicare, and I've got to renegotiate the whole thing. So it is very upsetting and daunting, I might add. Plus, the environment itself could be a factor. Chaotic or noisy surroundings can be a point of agitation for a patient who could then react poorly in those kinds of settings. Now, clinicians can also play a role in contributing to difficult patient scenarios. And you may not even be aware, but you could do so by being angry or defensive, or maybe you're displaying arrogance or annoyance regarding a patient's demands. So your attitude and behavior with the patient can also negatively impact the relationship. Now, that's not to say that you may have personal influences, like things like stress or feeling burned out, or maybe you're just very fatigued, and that reflects in your attitude and potentially influences your judgment. Another factor could be that you may have a known or unconscious bias towards particular medical conditions or certain cultural differences, and that can affect the way you handle patients that challenge your viewpoints. And we do have a really good webinar on implicit bias as well. Each experience is truly unique, and the level of difficulty can vary, as well as each provider's ability to handle the situation. So how does this affect the quality of care? Well, those who treat a difficult patient may unintentionally impact the quality of care through avoidance of interaction that could result in delayed care, or taking an incomplete history and physical, possibly discounting symptoms that may represent a serious condition or a medical emergency. Or how about conveying an attitude that there's no medical basis for the patient's symptoms? Well, keep in mind with a difficult patient, communication problems may exist, and that contributes to the potential of missing a diagnosis or an intervention that might be relevant to that patient's care. Now on this slide, you'll see some common patient behaviors that you probably have already seen in difficult patient interactions. Clinical providers may experience one or more, a combination of these common patient scenarios. And I'm going to be going over some case examples and patient scenarios within the next few slides. So as I do so, consider some of these contributing factors and triggers that I've discussed that may play a part within those challenging situations. And I'm going to provide tips on how to reduce your liability during your interactions and show you some examples of de-escalation efforts, and then how to determine if de-escalation or termination is appropriate in that particular physician-patient relationship. Okay, so I'd like to go through some of these case studies and some legal cases and patient scenarios that I review. They may be similar to what you've experienced yourselves. Okay, so the first case that we're going to review illustrates why it's really important to lean on the medicine, to trust your medical judgment, excuse me, when you're confronted with a demanding patient that may be trying to coerce you to undertake a certain action. And in this case, a patient with COVID-19 was admitted to the hospital. After admission, the patient demanded that he be treated with ivermectin, and he threatened to sue the physician and the hospital if his request wasn't honored. Well, the doctor refused to prescribe the ivermectin. He cited a lack of effectiveness in preclinical trials. The patient turned around, filed a suit, and asked the court to order the physician to prescribe the ivermectin. Well, thankfully, the court sided with the physician and dismissed the lawsuit. So importantly, in dismissing this case, the court noted that allowing judges to countermand a doctor's decision could set a dangerous precedent. Had the physician in this case altered his medical opinion due to the patient's attempted manipulation, the defense would have most assuredly been negatively impacted because when you think about it, my patient made me do it, that's generally not a viable legal defense for an alleged breach of the standard of care. Demanding patients, they've been around as long as the practice of medicine, right? It's just part of the job. But there is a small subset of patients that are willing to go to extreme measures to effectuate their desired outcome, even if it runs contrary to their provider's professional judgment. So the previous case study, that's a prime example of this behavior. Now, to try and get what they want, some patients might threaten to post a negative online review. You've probably had that happen. They may threaten to have you or your practice canceled on social media, or they could even toss out that well-worn, "I will sue you" line. And that can be very unnerving to face a patient under those circumstances. It's difficult, right, to avoid resentment. While most of these threats are hollow, there's that rare occasion when someone is legitimately aimed at holding you hostage until they get what they want. When dealing with a patient who's trying to manipulate you into a specific course of action, it's always best to trust the medicine, trust yourself and your medical training. Giving in to the patient threats can be a recipe for disaster. Even if a patient follows through on their threats, dealing with a negative review or a social media frenzy is a lot easier, a lot less time consuming than defending a lawsuit that alleges that you deviated from your original plan simply to appease the patient. Now, this is also a good time to remind you that your HIPAA obligations make it difficult to respond to negative online comments. If you respond in a manner that might confirm or identify the complaining individual as a patient, you've just disclosed protected health information. So we generally recommend that you refrain from responding to online complaints or you can consult with one of the ProAssurance risk management consultants before responding. And we actually have a really good canned response. So if you need to get a hold of that, just give me a call. So what can you do when you're faced with that demanding patients? Well, one of the easier things you can do is to set limits right from the beginning. Let them know the frequency of office visits that you expect, when you're going to return phone calls, and when you're going to prescribe medications, how often. You can also proactively manage expectations. Demanding patients, they often have unrealistic expectations. Sometimes they've done some internet research with our favorite doctor, Dr. Google, or they've spoken with coworkers and friends or family, and their facts are based on inaccurate material. So with these patients, you might try explaining their condition and their treatment plan in very plain language. Patients will often turn to the internet or friends or family when they're searching for answers. But so when you provide those answers in a very digestible manner, then you decrease the need for patients to seek outside guidance. You should also try to determine the true motivation behind a patient's demands and consider that it could emanate from other factors, like a sense of helplessness or a loss of control. It never, ever hurts to talk through these issues with your patients. And these conversations can really strengthen the patient-physician relationship. But at the end of the day, never give in to patient demands that go against your medical judgment. Doing so could openly expose you to further liability. Now, the AMA Journal of Ethics, they published an article titled Managing Somatization Disorder. It was authored by Dr. Robert McCarran, and the article states that 40% of patients display somatizing behaviors, making it difficult for physicians to determine etiologies early on within the relationship. Now, in this write-up, it provides a table as a tool for working with the different types of somatoform disorders. And you can find this resource link and use it as a reference. It's at the end of this program, located on the reference slides. These patients are known as the worried well. You rule out one problem and the patient develops another one, or they come in with multiple and vague symptoms. They've been to many, many doctors over the years with their tests and their studies usually being negative or not matching the level of their complaints. Trying to identify the diagnoses and potential treatments can be cumbersome and, in addition, very time-consuming. But the key is to understand that in the patient's mind, they are truthfully reporting their symptoms. So advising them that their symptoms could be related to other changes in their life, that might be part of the treatment plan. How do we avoid escalations and how do we approach somatizing scenarios while increasing patient safety and reducing liability? Well, that's a very good question. And on the slide, there are some of our risk management tips. I'll run through them briefly. Recognize potential somatization symptoms like complaints that are vague and their past medical diagnostic history that reveals numerous negative results. You could try providing support by being sensitive to the possibility of these patients having anxiety or depression, maybe even personality disorders. Try to refrain from being dismissive of their concerns. And again, understand that in the patient's mind, they believe what they're reporting. Remain focused on treating the patient. With these types of patients, it's a good idea to take a good psychosocial history and also ask about their home and work life. You can ask them, are you under any stress? Are you worried or upset about something? You can point out to these patients that there was nothing concerning in their diagnostic workup, and often patients with such symptoms could be suffering from conditions that are related to stress, and it may be time to look in that direction. Remain focused on the treatment plan and include a mental health referral when applicable. To give you another look at scenarios involving a somatic patient, we actually have a video with some role-played characters for you. During the first half of the video, look for contributing factors and triggers that could potentially escalate the situation. And then during the second half of the video, pay attention to the de-escalation techniques that are implemented to achieve a positive resolution. So I'm going to go ahead and play this video for you.
Dr. Evers, thank you. Thank you so much for seeing me today. As you know, I keep having these unusual symptoms. That's why I'm here. And they're so hard to pinpoint. Now, some days I have this heaviness that's over my body and it's all over my skin. And it feels like these little needles that are poking me. And then other days when I'm really not that stressed, I have this sensation. It's like a warm sensation that's in my limbs mainly. But what's really awful, Doc, it's this tiredness. I am always so tired. Now, I'm scared. I'm really scared that I'm not explaining this well to you and it doesn't show up on these tests. It's just, I've been to so many doctors and I keep going through and I've gone through all these tests and I really just don't feel normal.
I'm sorry, Mona, but we've been over this numerous times. I cannot find a physiological explanation for your symptoms. I've simply run out of options and tests. I need to refer you to a psychiatrist. My staff will assist you from here with finding another provider. Mona, thank you for keeping me advised of these lingering symptoms. We will continue to work together to address them, but I believe the time has come to refer you to a mental health specialist. Cognitive evaluation may help us discover what is going on and help rule out certain conditions. I would like to continue to evaluate your symptoms by having you maintain a diary of these symptoms along with the activities you are engaged in when the symptoms occur.
Fascinating, huh? Both of these responses convey essentially the same information. But as you heard, there was an appreciable difference between responding in that first dry or dismissive manner versus responding with that level of engagement and empathy. Being able to effectively connect and communicate with somatic patients often goes a really long way towards putting them at ease. And it demonstrates that you are invested in the patient's well-being, even if their root issues cannot be definitively identified, right? In the preferred response, our physician took a little extra time to explain the situation. He empathized with the patient, he offered possible solutions, and he made it clear that he would continue to care for the patient. Now, of course, your real world conversations with the somatic patient is going to be more involved and it's going to take more time than what's portrayed in our example. But it is time well spent. You want all of your patients to perceive you as an ally on their quest for wellness. And this is especially true for the somatic patients. The next patient subset that we're going to discuss are those that fall into the drug-seeking category. And before I dive into that, I think it's important to provide a little context for the scope of the issue. The National Institute on Drug Abuse states that in 2019, nearly 50,000 people in the US died from an opioid-involved overdose. The misuse of and addiction to opioids, including prescription pain relievers, is a serious national crisis that affects public health, as well as social and economic welfare. So the Centers for Disease Control and Prevention estimated that the total economic burden of prescription opioid misuse alone in the US is approximately $79 billion with a B, dollars a year. Now, unfortunately, drug-seeking patient scenarios are common. Oftentimes, providers are quick to terminate these patients or simply avoid them altogether. Pain medication use is often associated with risky behavior and stigmas, and that may affect how patients are treated. Recognizing patients engaged in drug-seeking behavior can be difficult, But here are several common behaviors to watch for when you're trying to identify drug-seeking patients. They do include reports of continued pain from an injury that occurred years or even decades ago. It includes claims that an individual has built up a tolerance to their current pain medication. They may report symptoms that don't correspond with diagnostic test results. They also might report odd events, like things like, oh, I tripped over my pet and now my pain started again. And of course, a major red flag to watch for is when a patient asks for a prescription refill before the scheduled exhaustion date of their current prescription. So how, as a provider, can you take the steps needed to reduce risks related to drug-seeking patients? Well, here's some risk management tips when managing that type of patient. First, utilization of plain language and a pain medication agreement sets forth the terms of prescribing narcotics. And this would include no early refills and a submission to mandatory drug testing. Next, consider prescribing non-opioid pain relievers. Also consider referrals to physical therapy, maybe drug rehab centers or a pain management specialist, possibly a psychiatric specialist when it's appropriate. Also, if you believe the patient is requesting refills too frequently and you suspect a patient is misusing, abusing, or developing an addiction, or even selling the medication, you want to talk to the patient and express your concerns about their extensive requests for drugs. You can also advise the patient that you will not prescribe opioids. Discuss detoxification treatment centers if that's necessary, and be aware of the drug-seeking red flags. Most of you know that that includes a patient paying cash or attempting to use multiple pharmacies or seeing multiple physicians. Sometimes patients request a drug by name and state that alternative drugs don't work. That can be a red flag. And they also may recite textbook symptoms, calling for early refills and saying they cannot obtain their prior records for your review. You should also check the prescription drug monitoring programs. These are state-run databases and they track the prescribing and dispensing of controlled prescription drugs. They're available in all states. So the prescription drug monitoring programs are designed to monitor for suspected abuse or diversion. They can give you and the pharmacists critical information regarding a patient's controlled substance prescription history, and they'll help you to identify high-risk patients. Now, I know we harp on the importance of documentation all the time, but it really is one of the best ways to protect yourself. And that is especially true when you're dealing with drug-seeking patients. There should be thorough documentation of all prescriptions and also over-the-counter medications taken by the patient, along with documentation regarding any herbal or over-the-counter supplements, mostly for purposes of determining and avoiding any adverse side effects from your multiple drug intake. Also document any objective signs of drug dependence and all treatment plans that you've discussed with the patient. And then finally, when dealing with drug-seeking patients, consider termination only after all efforts to rehabilitate the patient relationship have been exhausted, but the patient continues to demonstrate drug-seeking behaviors. Now I'd like to work through some de-escalation techniques along with our risk management tips for when a patient presents with possible drug-seeking behavior. Excuse me. Okay, so in this scenario, a patient claims that he still has neck pain from a car accident that occurred 5 years ago, and he's built up a tolerance to his pain meds. The patient also claims that his pain has recently worsened after a fall off of his mountain bike, and he admits that he's exceeding the prescribed daily medication limit. The patient then asks for a new pain medication prescription. Now, in response to this patient's request for more pain medication, the physician explains to the patient that his exams remain unchanged, that the medications sought have contraindications associated with overuse and can be dangerous when they're not prescribed or taken as prescribed. Instead of more meds, the patient is being referred to a pain management specialist. And it's also recommended that the patient receive alternative pain management treatments like physical therapy and maybe even massage therapy. Well, at this point, if the patient grows agitated with this response or accuses the physician of being unsympathetic, the physician should attempt to de-escalate the situation. And that might sound something like this. Okay, so the physician would say, I am not discounting what you're experiencing, but now that you've reported a potential tolerance to your pain medication and your pain scale remains elevated, referring you to a specialist and for alternative pain management treatments, that's the next appropriate step toward a long-term pain management plan. And based on what you've told me, we also need to revisit the side effects of narcotic pain medications, addiction potentials, and other risks associated with overuse, which can include overdose and death. I also want to discuss a pain medication agreement with you, which will cover any narcotic medication that I prescribe, your pain management specialist referral, and your complete treatment plan as it relates to your pain. Okay, so this approach made it really clear that the physician's decision-making is guided by an established medical protocol, but it also sets clear limits while simultaneously demonstrating that you are invested in finding solutions to help your patient. It also helps your patient to better understand that you're not simply out to make their life more difficult or that you think they're lying about their symptoms. I'd like to pivot a little bit and discuss non-compliant patients. I'm sure you've all had to care for them at one point or another. So this is a case study of a claim involving a non-compliant patient. During a 10-week period, a 24-year-old law student had 6 counseling sessions with a psychiatrist at a student clinic. The student had a significant history of behavioral health issues. The psychiatrist prescribed an antipsychotic medication and diagnosed the patient with delusional disorder grandiose. Now, as an aside, the psychiatrist recognized that the patient exhibited symptoms of schizophrenia, but he decided to document a more generous diagnosis because he believed that the diagnosis of schizophrenia would deprive the patient of the opportunity to practice law. At the 4th session, the psychiatrist informed the patient he was retiring, and the patient was instructed to continue therapy with another psychiatrist. Well, the patient didn't accept this referral offer. At their final session, the psychiatrist provided the patient with a prescription for a 30-day supply of an antipsychotic drug, and he told the patient to contact his replacement at the student health center to have his prescription refilled. Well, the patient exhausted his supply of antipsychotic medication, and he did not seek subsequent behavioral health treatment. 8 months later, after a gradual increase in psychotic symptoms, the patient became delusional and fatally shot 2 other students. He was charged with murder, but found not guilty by reason of insanity. Following the criminal trial, the patient filed a malpractice lawsuit against the psychiatrist, alleging, among other claims, that he was abandoned when the psychiatrist retired. His argument rested on the psychiatrist's failure to stress the importance of seeking further behavioral health treatment and continuing antipsychotic medication. The patient's experts testified that the psychiatrist should have referred the patient to a specific therapist and ensured that an appointment was set. The jury awarded a $500,000 verdict. However, the verdict was overturned on appeal. Although the jury verdict was eventually overturned in this case, the psychiatrist clearly did not expect to spend the first years of his retirement testifying in a murder trial and then enduring a malpractice trial. So with that said, personally referring and arranging follow-up appointments may not be necessary for every patient, but in this case, this psychiatrist might have avoided a lot of trouble by more thoroughly ensuring the continuity of care for this particular patient. Admittedly, this case is atypical, but it does highlight a potential worst case scenario when you're dealing with that non-compliant patient. And more importantly, this case demonstrates that non-compliance can come later in the relationship or even after the relationship has ended. When dealing with non-compliant patients or patients that you suspect may become non-compliant, you should emphasize the importance of prescribed treatment plans, and the risks associated with non-compliance should always be thoroughly discussed. Also, comprehensive documentation of these discussions is very crucial. That can significantly bolster your legal defensibility. When all else fails, non-compliant patients may be subject to termination, but take note, there are many nuances to consider when it comes to terminating a patient. Now, Stacy will be discussing these nuances and patient termination more thoroughly later on in the program. And now I'm going to turn the program over to Stacy. So thank you very much.
Thanks, Kathy. Good evening. Let's talk about conflict triggers. Conflict triggers can create difficult scenarios that tie into potential clashes within the physician-patient relationship. A list of triggers is shown on this slide. Personality conflicts with the patient and medical staff, including physicians, may result in the patient becoming angry. A patient's personality may appear difficult, which may prove challenging to some personnel to handle. Unanticipated outcomes can be upsetting to the patient. Individual expectations of an event may vary with each patient, despite applicable informed consent. Anger is the way that many people respond to unmet needs or expectations. Most of the time, the anger, rightly or wrongly, is directed toward the physician because they are the most convenient and visible target. A patient's needs are unique to the individual. Although care standards may be in place, the perception of how care is delivered may trigger patient behavior to become negative. Interpersonal triggers may be relative to a patient's reaction to a situation. These triggers include how communication is delivered and received, the surrounding environment, and the patient's attributing medical conditions. Their behavior may prove situational to the occurrence, or they may linger. Malpractice claims statistics have historically proven that patients are less likely to engage in litigation against a caring provider. Poor customer service may lead to service delivery failures. These interactions can result in unresolved upset and can cause distrust of the medical services that are provided. De-escalation tips are useful when engaging in challenging patient encounters. Let's summarize how these can be helpful. In order to stay in control of a negative situation, it's important for you to understand the ways that you may contribute to a potentially positive or negative outcome, as seen in our patient case studies and patient scenarios. Be aware of how your communication style, your body language, can assist in triggering or de-escalating a negative situation. Identify potential contributing factors or triggers that may be stressors. Once identified, you may be able to help reduce these stressors, such as moving an angry patient away from an audience, inviting them to sit, and talking in a calm, controlled tone while allowing them to express their upset. Or, with a somatizing patient, being supportive while setting a focused agenda. It's important to actively listen during patient discussions and to repeat what is said to allow the patient to see that you are engaged. Validating the patient's feelings may also reduce the level of stress contributing to the upset and difficult atmosphere. Validating their feelings does not mean that you must comply with the patient's demands. Maintain good medical judgment and stay focused on the appropriate medical care intended. Be supportive of the patient's medical concerns and set limits, as well as reasonable expectations. Let's look at our angry patient case now, and this is one you can probably all likely relate to. This is from the January 2019 Claims RX, which was titled Approaches to Managing Disruptive Patients. So on a Monday, a woman presented to the emergency department via ambulance with lower back pain reported as a 10 on a scale of 1 to 10. She was given Percocet, which eventually diminished her pain to a 6 out of 10, but within the hour she was back at a 10 out of 10 and began loudly moaning and squirming on the examination table. She was then given IV pain medications, which brought her pain down to a manageable level. She was discharged with a diagnosis of muscle strain and given prescription for Percocet and muscle relaxants, and she was instructed to follow up with her primary care physician. The next day, the patient awoke with excruciating back pain. The Percocet and muscle relaxants were not giving her any relief, so she returned to the emergency department via ambulance. The emergency department physician on site that day ordered an MRI, but when it was attempted, the patient was still unable to lie still because of the pain. She begged for IV pain medications to help her get through the MRI, explaining to the radiology tech that the IV drugs she had been given the previous day had worked. The radiology tech reported the patient's inability to tolerate the MRI to the emergency room physician and relayed the patient's request for additional IV pain medications. The emergency physician ordered oral Percocet as a treatment plan to try first, and then try stronger pain medications if the Percocet did not achieve the pain relief necessary to allow the MRI to go forward. The emergency department physician did not review the patient's record from the previous day. The patient was taken back to the waiting room, where a nurse brought her oral Percocet and explained it would relieve her pain and allow her to lie flat for the MRI. Very loudly, with a sprinkling of expletives, the patient informed the nurse that she had been taking oral Percocet for the past 24 hours and it wasn't working. She then demanded to be given the same IV pain meds that she had been given the previous day. The nurse informed the patient that injections were not given in the waiting room. When the patient's husband asked when the patient could get the MRI, the nurse replied, "Well, it'll be a while." Hearing this, the patient loudly made vague threats about hurting people if she didn't get the IV meds immediately. When the nurse gave her a warning about her language, telling her she would be removed from the premises if she did not calm down, the patient demanded to see a physician, refused to leave without getting an MRI, threatened to hire a lawyer, and continued to swear and moan in pain. The security guard at this point determined that the patient met the criteria for being removed from the premises, and he wheeled her out to the parking lot. 1 week later, the patient got an MRI, which showed a marked spinal cord compression due to an epidural abscess. Emergency surgery was performed, but the patient sustained permanent neurological deficits, and she sued every person on her healthcare team. So it's important to have guidelines in place for managing patients who are exhibiting disruptive behaviors, such as the patient in the scenario I just described. Additionally, consider building flexibility into your guidelines to allow clinicians and staff to respond accordingly, depending upon the level of danger to those in close proximity. Your guidelines should include tips for de-escalating conflict, such as staff members avoiding displaying behaviors that may trigger angry responses from a patient, and how to handle interactions should a patient become overly aggressive. The objective of the guidelines are to help clinicians and other staff maintain professionalism and to focus on patient care while resolving the conflict. As Kathy said, we always harp on documentation as a source of defense, so be sure to document all patient interactions thoroughly. If all attempts at resolution have been made without success, termination of the relationship may be necessary. So let's review some overall risk management considerations. The case scenarios and claim study examples have brought to light some situations likely to occur in your professional worlds, if you haven't already seen them. Let's discuss these tips to increase patient safety and reduce potential liabilities. Identifying what is causing a patient's disruptive behavior can help de-escalate it. the patient and their behavior or personality traits, the environmental stressors, medical staff or clinician's own attitude can be identified as contributing factors that lead to difficult patient encounters. Triggers may also have the same effect as they relate to negative escalations resulting in poor outcomes. Be cognizant of these contributors as well as the common patient types. Recognizing difficult patient types can aid in your communication during your difficult patient encounters, as we discussed in the various patient scenarios. Also, disruptive behaviors can be triggered by what you say, how you say it, and how you behave. For example, making a demand of compliance while speaking in a rushed or annoyed tone. Communication efforts should be made with patience, respect, and understanding. Documentation of every patient encounter, examination, and treatment plan should be thorough. Behavioral contracts, as well as pain management contracts, may be applicable to these situations and should be placed in the patient's chart. Set expectations for patient behavior at the beginning of the physician-patient relationship. This can signal to patients that disruptive behavior will not be tolerated. Patient rights and responsibility statements, patient brochures, and behavior contracts are ways to communicate behavior expectations. Staff should be trained to recognize contributory factors, triggers, and to understand all policies and procedures regarding patient behaviors. De-escalation training for clinicians and all staff members is a beneficial tool to assist with some of these encounters. Some of these tips were mentioned earlier in a previous slide, and you can also find some additional tips through the Joint Commission resource titled CPI's Top 10 De-escalation Tips. This web link can be found on our resource slides at the end of this program for your reference. Efforts should be made to attempt to rehabilitate the physician-patient relationship. Not all disruptive patients need to be dismissed from the practice. Some patients may need a reminder in the form of patient behavior agreements or written warnings following a disruptive incident. Once a patient is informed of behavioral expectations and the consequences of violating expectations, they may cease being problematic. However, if the patient's behavior continues to be problematic or violent, termination of the relationship may be necessary. I'm going to go over termination and the steps to take to avoid abandonment claims and in the next segment of our program. We would be remiss if we didn't at least briefly touch on the topic of workplace violence when discussing difficult patients. The Bureau of Labor Statistics reports that 16,890 workers in private industry experienced trauma from non-fatal workplace violence in 2016. Of those victims who experienced trauma in the workplace, 70% worked in the healthcare and social assistance industry. The rising trend of violence in healthcare has brought awareness to the industry. The infrastructure of a safe culture practice should include policies and procedures on handling violent occurrences. Mock drills provide the extra steps of preparedness for such situations. Many healthcare advocacy organizations have been proactive in assisting with educational efforts on how to build safety measures involving workplace violence. The American Society for Healthcare Risk Management's Workplace Violence Toolkit is a great example of such efforts, and I highly recommend that you review that material. Luckily, most of you will never have to deal with a workplace violence scenario, but you will assuredly face difficult and sometimes challenging patients. Some patients will behave in a manner that forces you to consider terminating the physician-patient relationship. When patients make threats or endanger other patients, ending the relationship is typically a straightforward affair. Things get more difficult when dealing with overly demanding, distrustful, or difficult patients. And some commentators argue that a physician's ethical duty to treat also includes a duty to repair damaged relationships with patients. The argument goes like this: the duty to treat dictates that a physician has an ethical obligation to offer interventions necessary for improving the patient's health. A damaged physician-patient relationship poses a potential threat to patient health and compels the physician to intervene. Beyond the ethical considerations, practical considerations should also be accounted for when contemplating the termination of a difficult patient. Studies have demonstrated that communication and rapport breakdowns increase the likelihood of a patient's suit, whether or not an error actually occurred. Against that backdrop, it's generally recommended that physicians engage in a good faith effort to repair fractured relationships with patients. When your efforts to manage a difficult patient are not successful, you can consider terminating the physician-patient relationship. Understand that terminating care or refusing treatment to a patient because of the patient's sex, race, color, religion, ancestry, national origin, or physical disability must be avoided. However, terminating a patient is appropriate and ethical in a variety of circumstances, such as repeated failure to keep appointments, noncompliance, failure to pay bills, or violent, threatening, or offensive behavior. The appropriateness of a relationship termination depends primarily on two issues. One, the reason for the termination, and two, the reasonableness of the time period given for the patient to find a new physician. You cannot unilaterally discontinue a relationship with a patient without adequate notice to allow the patient to obtain necessary medical care. It is important to understand that premature or improper withdrawal of a physician from the relationship may be considered abandonment. In most states, the law does not define adequate notice, but generally 30 days should be sufficient for most patients. However, be sure to follow any state statutes or guidelines in your particular area of practice. Also, be sure to resolve acute medical conditions prior to termination, and a longer time frame, such as 45 to 60 days, might be needed for a patient with no alternative source of care. Conversely, if physical threats or violent behavior are the reason for the termination may need to go into effect immediately in order to protect the physician, staff, or other patients. You should not hesitate to contact the police in the event of violent behavior. Termination may also be appropriate when trust between the clinician and the patient cannot be repaired. No matter what the circumstances are, it is important that you are cognizant of a potential patient abandonment claim when terminating a patient, and you should take the necessary steps to reduce this risk. That said, in most situations, the risk of a viable patient abandonment claim is fairly low. However, there are a few key exceptions that carry a higher risk for an abandonment claim and require providers to take additional steps before terminating a patient. When dealing with members of a managed care plan, your contract with the health plan may require a specific protocol that must be followed before ending your relationship with a member patient. Also, OB patients and patients in rural areas present their own unique set of challenges, as the following case examples illustrate. So, one case has facts that are as follows. A patient in labor presented to an emergency department, and the OB on call had previously dismissed this patient from his practice. So when she appeared in the labor and delivery emergency room, the OB refused to provide medical treatment. The hospital then removed the OB from the call panel based on his patient abandonment. The OB appealed this decision and lost. If you dismiss a patient early in pregnancy and you are on call when this patient presents to labor and delivery, absent extreme circumstances, you should strongly consider treating this maternal patient. During the first and second trimesters, it is possible to dismiss a pregnant patient, but it should be done with the utmost care. If the pregnancy presents any complications, it is generally best to avoid patient dismissal and to consider appropriate referrals when needed. Once a patient reaches the third trimester, dismissal is appropriate only in very unique circumstances, such as the provider suffering a sudden illness. At this point in a pregnancy, patients need continual prenatal care. Additionally, other providers may not accept a patient who is already this late in a pregnancy. Now I'd like to talk about a rural patient scenario. Like pregnant patients, patients in rural areas carry special considerations that must be accounted for prior to terminating the physician-patient relationship, as the following case demonstrates. A diabetic patient visited his family doctor monthly. Over time, the patient became combative and refused to give himself insulin injections. The doctor terminated the patient with a 30-day notice letter, even though the doctor knew that there were no other providers within a 50-mile radius of the patient, and that the patient's only viable option was travel via bus, which you can only imagine how difficult that would be. The patient was unable to timely procure a subsequent provider and ultimately suffered vision damage and sued the doctor. The doctor in this case was ultimately deemed liable for patient abandonment. Just because a patient may have difficulty finding alternative medical care does not mean a doctor must continue a problematic physician-patient relationship. There comes a time with some patients when it might be better for them to seek care elsewhere. In the previous case, the patient's noncompliance prevented the physician from being able to appropriately treat the patient's diabetes. Termination would likely have been appropriate had the physician taken steps to ensure continuity of care for that patient. Physicians in isolated or rural areas and specialists who are sort of the only game in town, they need to be especially careful when dismissing patients. Even if a physician believes the patient has been given ample notice, the individual patient's circumstances may preclude him or her from finding new care, and the notice interval may not be legally or ethically sufficient. So, when considering termination of a rural patient, weigh your ethical duty to treat against your right to terminate. Consider the seriousness of the patient's condition. Seek guidance from risk management or your attorney if patient circumstances will make obtaining alternative care and treatment difficult. So let's look at some of our risk management recommendations that pertain to all patient termination situations. First, develop a clearly defined patient termination policy. This will help ensure that all patients are treated in the same manner. Be sure and resolve any acute medical conditions before completely severing the relationship. For example, if a patient is in the process of a diagnostic workup or in the immediate postoperative stage, it is generally best to delay ending the relationship until the acute phase has passed. Consult with a managed care plan liaison when applicable. This will help ensure that you are fulfilling your contractual obligations. And stay informed about your local rules and regulations. This will help ensure that you are providing patients with adequate notice as it is defined within your specialty or jurisdiction. Send a termination notification letter via certified mail with receipt and include referral sources, if available, the date your interim care for the patient will end, a statement indicating that records will be available to the new provider upon receipt of the patient's authorization, and retain a copy of the letter as well as the return receipt. It is critical that you have evidence that proves that the patient received the termination letter. So this brings us to some closing thoughts that Kathy and I would like you to consider within your own professional settings. Disruptive patient encounters are inevitable, and you may have already experienced some. Many difficult patient encounters are patients that simply are responding to unmet needs or expectations. These situations and other escalated situations can be risky from a worker safety, patient safety, and professional liability standpoint. So successful management of difficult patient scenarios depends on developing the skills necessary for recognizing risks and keeping everyone safe. It also requires policies and protocols that minimize liability risks and can help to safeguard the well-being of clinicians and staff during a disruptive event, as well as protect other patients. It is a necessary duty placed upon clinicians and staff to adjust problematic patient expectations, discover what has triggered the patient's unacceptable behavior, and solve the problem when possible or offer alternatives when appropriate. Although termination of the relationship with a difficult patient may be the easiest way to handle a challenging or disruptive patient, in many cases, the better strategy is to understand the patient's complaint, empathize with them, and then attempt to reestablish behavioral expectations for moving forward in the physician-patient relationship. Ultimately, termination might be necessary in various scenarios. Be sure to take the necessary steps associated with termination to reduce potential liabilities, such as patient abandonment allegations, and plan for those requiring immediate termination, as well as crisis management in violent scenarios. This plan should include having a policy in place that describes the behaviors such as violence upon a staff member, which may be cause for immediate termination from a practice. We really appreciate you taking the time to attend our program today, and we hope that you've learned at least something new or are thinking about ways that your medical organization could be better protected.